Thank you for joining me on the Fire Rescue Wellness Podcast. I'm your host, AZ. I find the research and resources and then provide the fire service with the so what, now what, to ensure the health and well-being of every member of our profession. Together, let's thrive. My listeners, it's AZ. Thanks for landing on the podcast this week. I am trying to keep myself calm. This episode has been over a year in the making, and I'm so excited today to have Dr. Carrie Burns and her PA, Jeremy, on the podcast today. They are with South Metro Fire, and they talked about both the pilot study with doing the CCTA testing and also their first group of 309 firefighters that got scanned. Here's the punchline. South Metro Fire is finding cardiac disease in firefighters that have been risk stratified and found to have low or no risk. And they are finding significant disease in these firefighters. And so if we want to just say it like it is, they've probably saved more than one life through this testing. So you'll get to hear from Carrie and Jeremy today. Please, they invited you to reach out if you have questions. I will drop their email in the show notes. But without further ado, here is Dr. Burns and PA Jeremy from South Metro Fire. Hey listeners, it's AZ with Fire Rescue Wellness, and I am super excited today. A long time in the coming. I'm here with Dr. Carrie Burns and Jeremy. Do I refer to you as PA Jeremy? What do
Jeremy's
I refer to? Just Jeremy?
Jeremy works. Yeah.
I'm here with Dr. Carrie and Jeremy from South Metro Fire. Welcome to you both.
Hello.
I just cannot tell you how excited I am because I've just been waiting so long to talk about your study that you have going. So first off, though, I just want the listeners to know who you are. So we're going to start with you, Dr. Burns. Can you just give us kind of the down low? Who are you?
Yeah, I'm Carrie Burns. I am the Health, Wellness, Occupational Physician / District Physician at South Metro Fire. Been here almost 3 years now. My heritage is in emergency medicine, and I am super stoked to be here today and talk to you about CCTAs and what's been happening.
I am bursting at the seams. All right, Jeremy, it's your turn. Let's hear about you.
Yeah, I have been a physician assistant for about 5 years, and I've been with South Metro for a year. And my background prior to South Metro was primary care, briefly a little bit of urgent care as well. And from Colorado, went to the University of Colorado for both undergrad and PA school. But yeah, excited to be here.
Incredible. And I know that probably most of my listeners listened to the previous episodes with several different South Metro employees, but I do want to just, in case we have new listeners, Carrie, can you tell us a little bit about the medical model at South Metro, how you take care of all those firefighters?
Sure. So we have a very robust wellness department, and myself and Jeremy are primary. We do all of the work comp and some personal things as well, but primarily work comp. We have a very strong team associated. We have 2 athletic trainers, 2 physical therapists, 3 strength and conditioning coaches, part-time dietitian, and we saw, you know all the numbers, how many people we've been seeing. It's been pretty impressive. Like the rehab team had 470 visits last month.
Yeah.
Something like that.
Good grief. That's incredible. And I'm going to refer the listeners back to the previous episodes. I will actually link those in the podcast notes. But now that we kind of know what's going on there, I want to know about, I'm going to use my finger quotes, I want to know about the project and how that even got started.
Sure. I'm going to back up and first of all, talk a little bit about CCTA And that stands for coronary computed tomography angiography. It's a mouthful. So I use CCTA. It's a lot easier to say. And Jeremy and I just got back from an awesome conference on it. It was in Scottsdale. It was beautiful to go from Denver to Scottsdale for a short period of time and get out of the cold. So fundamentally, CCTA has also been referred to as a non-invasive cardiac cath. But what it is a CT where we use contrast to highlight the coronary arteries. And from that, you can see plaque and blockages in there. And then when you augment it with AI quantitative plaque analysis, not only can you see the plaque, but you can see the quality of the plaque. And really, when we'll get into it a little bit later, quality matters a lot.
So, but, I'm just going to be a little bit controversial here maybe, but can I just go get an EKG, and can I just go get, a calcium score? Isn't that good enough? Why do I need this technology? Right.
So actually, at South Metro, we used to have a physical that involved EKG, some other measurements, including echoes, IMT, carotids, and also if you're 55 and older, we did a stress echo. And guess what? It missed people. And in fact, I think we had a line member have a big MI 4 days after being cleared from the physical, including a stress test. So in examining what we were doing, we were able to partner with South Denver Cardiology. We did a small program in one summer where we took some patients, and some got a calcium score and some had CCTA. And the results were so overwhelming for the quality of information that we got out of CCTA that we said, this is what we want to do. And all of you who got the calcium scores, we're going to do CCTA.
That really speaks to the value of this intervention. And you mentioned that you had a member that had all of the testing, and then I believe you said 4 days later had an MI, but that's not the first time I've heard that story.
No.
A member on my own department, I believe his physical was that day, and he was all cleared, and then had a cardiac issue on a call. So that's incredible. So once you decided that, isn't it Yoda that says this is the way? Some Star Wars character. Once you decided this is the way, how did all that evolve?
Well, that was a big decision. It was a big decision for the program financially. There was a lot of work that went on behind the scenes, getting associated with imaging centers, deciding what AI plaque analysis company we were going to use. We picked one to keep it the same. There are at least 4 that I know of right now, and they all have their strengths and weaknesses. The one we went through had, for myself and Jeremy, one of the best user interfaces where you could sit down side by side with the line member and go over their scan in detail. So we had to arrange all of that. And then you have the big beast of arranging scans for people and getting them in, getting their heart rates low, getting the follow-up done. So it was, I'm not going to lie, it was a massive undertaking, but I'm so happy we did it.
Jeremy, is this something that you had experience with prior, looking at these scans, or was this you were trained on the job?
Yeah, so I think it kind of goes back to what you're asking about, are other tests good enough? Because I guess the answer is no. I hadn't done this before, but a large part of that is because it's just not done in primary care in the general population. And so there's other ways to risk stratify heart health, whether that's like, when you go to your PCP and you want to know, hey, what's my chances for having disease in my coronary arteries, you're going to, check your cholesterol. And then there's basically like these risk stratification calculators where you can ask, age and smoking status, obesity, diabetes, all these things to basically say, okay, this is your percent chance of having an adverse cardiovascular event due to coronary artery disease in the next 10 years. So that's what like you do in primary care. And so when it comes to CCTAs, like my knowledge of CCTA, and I think this is true of most people's knowledge of a CCTA across the country, is that it's a tool that you use when somebody's having chest pain in the ER to make sure that they're not having an acute heart attack. So I actually never even really knew of it as like a preventative scan, but there's a lot of research now that shows that with these risk stratification calculators, with calcium scores, with stress tests, it all underestimates the risk of cardiovascular events compared to the CCTA. Yeah. So that's a long answer to say no.
Yeah, there was this great big trial in Scotland, and I think it had over 4,000 Scotsmen and women in there. And they had one group that had the standard evaluation, so your EKG, stress test, those kinds of things. So that group, and then they had the group that got CCTAs. And they followed those people for almost 5 years. And what they found was the CCTA group had 41% less major cardiac events and death. So it was the CCTA group found things, they addressed things, and because the imagery, when you sit down and go over your scans with someone is so powerful, their patient compliance was far greater than the other camp. So we found that not only are we finding stuff, but patients are also engaged and they're doing the things to help reduce the risks.
And I think that therein lies the magic.
Yes.
Because so many times we talk to clients, in my case clients, in your case patients, and we tell them about all of the good things that they should do for themselves, and then it just sort of falls on the deaf ears. Wow. I want to then, so you decided this is something that you want to try to pilot, and I understand that there were probably some hills, valleys to overcome. Yes. How did that whole process look?
Boy, there was, I think why we were successful eventually, because we did end up scanning 309 line members, was one, we knew it was the right thing to do, and we had a lot of perseverance, and we were also very open-minded and flexible. So if we had to pivot, we just pivoted and kept working.
The fire service is 200 years of tradition unimpeded by progress. And so I can't imagine putting this in place. So you did, though, an initial really small pilot study with, was it 20 members?
So there were 23 who had CCTA in the pilot. Yes.
Okay.
Yeah.
And can you give us kind of the wave tops of what you found in that original pilot, just as a reminder?
Right. So what kind of compelled us forward was that I'm trying to remember all these numbers. So I have two groups in my head. So the pilot group, we did have 2 patients out of that small group who ended up needing a cath and had stents placed. So out of that small initial group, we had 2, and both of them had significant disease with their 5-year risk was through the roof when we saw not only the lesions, but the quality of plaque around those lesions. And so they were the ones that kind of were like, yeah, this is super important information. And one of those, drum roll, I think was about 50 or 51, his CAC score was 0. So he would have been totally missed. If he'd gone to another spot and they said, okay, let's do your calcium score, it was 0, it'd been great, we'll see you again in 5 years.
And in 5 years, it would have been too late.
Right. Yes.
That gives me chills.
Yes.
So I'm kind of meandering. I promise I'll get to the point. But I remember as a younger firefighter, we were offered the calcium test, I
Mm-hmm.
believe, one time once we turned 40. And I think if we wanted to do it again, we had to pay for it. I was very proud I got a 0 on that test. But with your CCTA tests, let's say I get a great reading, a great output, whatever you want to call it. How long am I good before you scan me again?
If you have like 0 plaque, you're probably good for at least 10 years.
Oh.
If you've got nothing, and it's kind of age dependent, like the older you are and you have 0 plaque, then, you just keep pushing that out further and further. And if you have a little bit of plaque, it kind of depends on the quality of the plaque in there. If it's more of a high risk plaque, then we might do it again sooner rather than later, meaning like 3 years versus 5 years. So there's kind of lots of moving things with it, which is the beauty of it, because it's not just, do you have plaque? It's what kind of plaque do you have? Where is it? What can it do?
Let's dig into that now, because I didn't know there were different kinds of plaque until recently.
Mm-hmm.
Tell me about all the plaque.
You want to talk about?
Yeah. So yeah, the CCTA will show you whether or not you have plaque, and the big thing that we're using to determine the risk within that plaque is that's where like the AI programs come in, and so the AI can basically distinguish whether or not you have calcified plaque, soft plaque, or this like LDL rich plaque, which is kind of like a more high risk, early stage, or like necrotic core plaque. And, part of the reason why it's superior to the calcium score is like the calcium score is only going to show you if you have calcified plaque. So for example, you can have an occlusion of just soft plaque. And we had a guy who, that Dr. Burns mentioned, the person who had a calcium score of 0, he would have just had soft plaque identified on the CCTA that you would have never picked up on a calcium score because it's not calcified. And so that's kind of the distinction between the CCTA and the calcium score, is that like the calcium score is not good enough in determining whether or not you have this stenosis, because you could have a completely only, soft plaque stenosis that is enough to cause ischemia and eventually like a cardiovascular event.
And is it something genetic? Is it something lifestyle related that determines, let's say AZ has plaque, but what determines whether it's the calcified plaque, the soft, or you said LDL?
Yeah. So, I mean, like whether or not you get plaque is totally multifactorial. I mean, so for example, there's obviously lifestyle drivers like obesity, smoking, diabetes, hypertension. Those things are going to cause plaque buildup. But then I think everybody knows, like, anecdotally, a story about somebody who was like a vegan marathon runner who had an MI, and there's like these genetic conditions where you just have the propensity to collect plaque in your arteries, and so it's multifactorial. And I think what really makes it important to do in the firefighter population, though, and why we're doing the CCTA and not just calcium scoring people, is that there's a study in LA that showed that firefighters, independent of any other risk factors, so controlling for all those lifestyle risk factors, have a 41-point higher calcium score than the average population. So don't really know why exactly firefighters have a higher incidence of coronary artery disease, but they do. And so that's why we're not just relying on like risk stratification tools and calcium scores, because we know that firefighters have a higher risk even when you control for all those lifestyle things. So when I ask a patient in primary care, do you smoke? Are you hypertensive? Yeah, that helps. But there's also like this firefighter risk factor that we don't have our finger on yet. And so that's why we have to scan these patients to like visualize the plaque.
Towards the end, I'll ask you to speculate, but I won't ask you that yet.
Okay.
So we kind of talked about what is this test. We talked about what information we get from the test, but can we back it up even a couple steps and tell me, as a patient, so I'm coming into your office at South Metro or wherever you send me for this test, what is the preparation for the test? How long does it take? Tell me all of those details because I know the listeners are dying to know.
Sure. So this is a thing where quality matters, and part of the preparation is typically for patients to take a beta blocker about 8 to 12 hours before the test, and then a couple hours again before the test. Ideally, you want the heart rate less than 50, but there are scanners now powerful enough that if your heart rate's above that, they can still go ahead and get the test with good results. Our population, as you know, is fairly fit population, so we actually have a lot of line members whose heart rate lives less than 50. And in those counts, we don't give them any pre-medication. So you show up for the test. Important to limit your caffeine intake, go in hydrated, all of those things. They will put you on an EKG. They'll start an IV for the contrast, get you all snuggled into the CT bed. And essentially then the timing is with the ECG, the administration of the contrast. And I had one myself, and it was really interesting. And the contrast was kind of funny because I felt it in the back of my throat, and it kind of went through, like the tech told me it'd go through your body, and it ended up like going out my right big toe. It's just this wash of warmth through there. But
that's wild.
Yeah, it was kind of crazy. So if everything is slick and heart rate's controlled, and we don't have to give a little extra medicine to get the heart rate lower, the actual acquisition of the images is seconds, and the whole test could be in and out in less than 15 minutes.
Can I go back to work after I've been on a beta blocker for the tests?
I will say it depends. We do not do them on days where people are working, just in case. But some people's metabolism just chews it up and gets rid of it so fast that it doesn't really matter much.
So I walk into the scanner, have the test on a Monday. How long does it take before you and Jeremy have results in your computer?
Same day.
Monday. Yeah. So typically 90 minutes to a couple hours. Yes. It's so exciting.
Wild.
Yeah. It hits the inbox. And when we're scanning, I look a lot at our inbox to see as the results come in. We take a quick look at the results and see, first of all, does this patient have anything that needs urgent action from us? So do we need to talk to cardiology or intervention? Do we need to bring this person in same day and go over the results immediately? Or can they wait to normal follow-up? And it was kind of funny that at some point people were just calling it the call. Like, did you get the call? Same thing. So,
Carrie, how much did you deal with firefighters before you became the doctor for South Metro?
Actually, quite a bit.
In the ER.
Yes, in the ER. So working alongside them, and then when I was in Arizona at Flagstaff Medical Center, I was medical director for various agencies. So I worked with them quite a bit.
Right. So you had some experience. I'm going to assume that poor Jeremy your hair was blown back when you walked into the fire department, wasn't it?
Yeah, I've never known, but there was no firefighters in my patient panel in primary care.
We are so weird, and I am so sorry.
It's a different population.
Yes. And so if I am tracking correctly, you had that initial pilot with between 20 and 25 people, and then you've scanned, I think you said 309 people.
309
is that right?
Total. Mm-hmm.
So what's the punchline? Have you found anything else?
Yes. So, yeah, of the 309, we had 11 go to intervention, 6 of those on an urgent basis, the other 5 electively. Of those, 9 stents were placed. Well, actually 10 stents. Somebody got 2 stents. But nine of the patients were stented. And only recently it was brought to our attention that's actually a pretty high conversion rate to have a test where the quality of information is so good that you're catching the patient. They actually need that intervention. Whereas like even if you go and run on a treadmill or have a stress echo, the false positive rates with those tests varies anywhere from 10 to 50%.
Did you say 50?
I did say 50. That's what's in the literature. Yeah, so
What?
just depending on, the center that's doing it and those other factors, it could be a flip of a coin.
I just need a moment. This is crazy.
Yeah.
All right. So when you went to that second, I guess, wave of people, the 309 people, what were the criteria, the inclusion criteria for that group?
So we first was age. So the biggest one was age, 40 plus. And then each patient, I think, as far as who goes first versus who goes more to the end, is very individualized. So we actually looked at, every single patient. And so I think, first of all, like if you have a personal history of coronary artery disease, like maybe you got a calcium score 5 years ago and it was positive, or, really high risk factors like really high LDL cholesterol, family history, really important. Did dad have an MI when he was 38? Like those. So there are some like big high risk factors that you just screen for. So those people are obviously going to go to the front of the line. And then, age is a big factor as well.
And I believe when I spoke with you last spring, Carrie, you were saying that there was going to be yet another wave of people coming through. What are the criteria? What's the criteria for that wave?
So we just dropped the age down to 35. So it will be people who weren't scanned last year. And there were some people who might have had like difficulties getting their heart rate down or whatever. If they want to be included this year, we're absolutely going to do that for them. So we're just going 35 and greater. And that will be probably about another 150 people.
So how young does it make sense in this population to go down to? Is 35 the youngest that you would consider?
So we've scanned as young as 32. And definitely found plaque on that individual. And part of it, that's such a good question, Annette, because like there's all these like CAC scores have been around a very long time and have established timeframes, 40, 45 and older. We know that they're not very effective for people who are less than 40, definitely. And also if you have other factors such as you have metabolic syndrome, things like that, CAC scores are not as reliable. So, I think the big question is we don't really know the best age because not a lot of people are doing this preventatively. Now, Scotland is doing a preventative study. So they're taking it, plucking it out of and doing all a screening. So that's coming, but we don't have those results yet. But I feel pretty comfortable based on what we've seen at 30, going down to 35 and even younger if people are concerned. And here's the thing is you don't know you have heart disease or plaque unless we look for it. And here's kind of like some of the really scary statistics is, was it for people with CAC scores of young people with calcium scores of 0. 25% of all MIs in young people, 35 to 45, I think is the age range on that. 25% of those had calcium scores of 0. So I just think, we can go ahead. I feel super comfortable at 35. And if you get a diagnosis of 35, like, yes, you have this, guess what? You can impact it. You can stop progression. You can even cause regression. So you have control at that point.
I think the big thing too, just to add to that, is like we were asking, what the age is for this population. And like, I think Dr. Burrs' point is like, there's no guidelines, but most cardiovascular events, when you start treating for prevention, it's secondary prevention. So it's like you already had an MI, and so now we're going to put you on a statin. And obviously for a large chunk of those people, they never make it to secondary prevention. And so primary prevention is key. And so I think to maybe a lot of like healthcare providers who would listen to this podcast or learn about CCTAs, they would think like, okay, scanning even like a young, healthy 4-year-old is kind of ridiculous. But again, it's like we don't know what that firefighter X factor is that makes them more high risk for CAD. So it's like, then why would we just wait until they get a heart attack before we treat them?
Amen, and say it louder. One of the questions I wanted to ask you, because of course a portion of this is lifestyle, and you just said regression.
Mm-hmm.
How can we get regression of this plaque?
So here's again the gift of CCTAs is you can do it in studies. So you can scan an individual, rescan them years down the road on certain treatments. So we know that if you get your LDL somewhere between 60 and 80, you can stop progression of it. And below that, you can cause regression. And we have lots of tools to help people get there, and they can do their own lifestyle things as well. But we also, the world, it's not all statins anymore. It's a massive, massive world to help people with those.
Jeremy, I want to have you preach a little bit on lifestyle because they're tired of hearing the coach talk to them about lifestyle. They're tired of hearing the dietitian talk to them about lifestyle. So now you have the mic. Let's hear the PA talk to them about lifestyle.
Well, I don't know how much, my advice would differ from the traditional advice, that you get from your dietitian or from your strength coach. I mean, we know for a fact, and this has been studied on, so many different studies of like the most important modifiable risk factors. So there's unmodifiable risk factors, right? Which is like your sex and your age. Like the modifiable risk factors, number one is blood pressure. And then we have like obesity and diabetic status. And so like a lot of those modifiable risk factors, those are, when you talk to your dietitian, those are going to be changed through diet and through exercise. And so I can say, for sure, those are the things that are going to reduce your risk of developing plaque. I think too, from the medical side, and this is something that I like talking to patients about, is, I do really appreciate that a lot of people are hesitant to get on medication because it's kind of a scary thing to commit to. There's a lot of talk about, side effects with statins and different medications. And sometimes I kind of see it as like, there's sort of like a both and more approach of like, it's not like you're going to take a statin and never work out, or you're always going to work out and never take medication if you need medication. Sometimes you can try one thing, and if it's not working, you can try the other thing, or vice versa. There's people who work out really hard, but they can't seem to shed the weight, so they might get on a weight loss drug, and then when they follow that weight range, that reduces their risk, and there's no shame in using medication to achieve that. And on the other side, they might take medication and it doesn't seem like it's moving the needle too much. So they say, okay, I need to ramp up my diet and exercise game. So sometimes I feel like medicine and diet and lifestyle is like seen as this false dichotomy when really there's a marriage of it, and you just kind of have to talk to the individual person and see what works best for them.
What I've been telling people for the longest time is I think you almost have to assume that being a firefighter, you almost have to assume that medically things are potentially going in the wrong direction. The propensity for things to go in the wrong direction is high. So let's do as many right things as we possibly can, improving our sleep, improving our nutrition, our fruits and vegetables especially, improving our exercise, cardiovascular and strength training. And we don't have to know that there's something wrong in order to do those things that are good for us. But for some reason, I can't get through to people. They wait until something bad happens, and then they're like, oh, I got to get in shape. Really?
Yeah. And when it comes to cardiovascular stuff, you don't want to wait for an event, before you get in shape, because then you're just, you're just tempting fate.
Yeah. Okay. You've heard it now from the doctor and the PA. It's important. Do you think, we all know, I'm sure we can all agree that the medical model, traditional healthcare model, insurance model is a little bit broken.
Yes.
And you guys have a beautiful, lucky, whatever we want to call it, opportunity to take really good care of your people at South Metro. Do you think, however, that this should or eventually will become standard of care in the general population?
I think so. I do. I mean, like, let's look at colonoscopies. Talk about an invasive. Yeah. But, it's an invasive test. And not only, like, there's some invasion with it, but also you have to undergo conscious sedation. So there's a risk with conscious sedation, colonoscopy. I mean, and now that's covered under prevention with insurance. So, kind of why wait until you have rectal bleeding if you're over a certain age to get your colonoscopy? So I think that, this is a non-invasive test. It does have some risks like any test, contrast allergy and so forth with that. But being able to identify plaque early and taking care of it, the payoff is just massive. And I don't know what it will be to get it moved into the world of screening, but I'm hopeful that it will be.
And I think you can also look at just the history of calcium scores is, followed a trajectory of not really being accepted or covered to now being covered. And I think as more data comes out about how much more accurate CCTAs are, how low radiation dose they are, how safe they are, that'll change. And I think it's a difference between could and should. And I think a lot of times it just in the medical world change is very, very slow. And so it's is it tomorrow? No. But hopefully in the future, people have the same access to it as they do to calcium scores.
I remember distinctly the year that I got my calcium score. Another co-worker had his at the same time, and he came back and his calcium score was also 0. And in my head, I was thinking, how is this possible?
Mm-hmm.
This person does not work out. This person does not eat well. How is this possible? Now I understand how it's possible.
Mm-hmm. Yeah.
Wow. I want to ask you, switching gears just a little bit, because I think that we in the fire service and we as humans have a little bit of trouble advocating for ourselves in general with our physicians. In fact, I think there was a study, I can't remember when it was, but 80% of Americans, when you ask them who's in charge of their health, they said their physician. But yet, isn't that sad? But yet we don't communicate with our physicians very well. What tips can we give the listeners in terms of communicating with their personal physician who might not really understand their job and the importance of screenings that they might need above and beyond what the normal civilian would need? Give us words.
Well, I think that, it comes from, let me back up just a second. So I think that, getting informed is important. And I've had patients come into the office and say, there is this study that shows this. What do you think about that? And, we intend to write up our study, which is specific to the fire service. So that might be helpful. And also one of the things that we did was we calculated a score called a prevent score, which is like an ASCVD score. And what we found with that score was that it completely underestimated our population, way underestimated. There was, Jeremy, you remember, so in prevent score, generally, if you have a 5% or greater, it's time to treat, but of the population, only a small point ever reached that.
Yeah. The prevent score is the risk stratification calculator. So that's where, you ask the age and if they're smokers and things like that. And so it basically says, hey, what's your chance of having a cardiovascular event in 10 years? And then gives you a percent chance. And if you're at 5% or higher, that's when you want to start treatment or at the very least lifestyle intervention. And out of all of our members who had a significant level of plaque, only 4% of them had a risk stratification calculation of 5%, meaning that it was severely underestimating that.
Mm-hmm.
But I think to kind of go back to your original question, if I can kind of give a primary care perspective from it, because I am I definitely think a lot about patients advocating for themselves, especially in a primary care setting. And I've seen a lot of times where, when you're somebody's PCP they just come to you and they shouldn't necessarily have to know or do your job for you and say, hey, I need these screenings, because it's like, that's why we're here, is to help people walk through that. But I think like a level of openness is really important when you're finding a PCP, because I do agree with Dr. Burns of like, if somebody comes in and says, hey, I've done all this research, I want to pursue this, like I'm always happy to talk to a patient about like what they think is the right thing to do for them. And obviously, like, you know, I still have my training and knowledge of like, you know, you need this screen, you need this screen, you know, whatever is sort of standard medical care. But I think for a lot of patients, it's important for them to find a provider who has openness to have conversations of additional stuff. And you should never feel afraid to educate yourself more. And, you know, I think education is a long process for both patients and providers. So the more the patient can educate themselves and find a provider who's willing to engage with that, the better.
Yeah, that absolutely makes sense. You mentioned that you were just at a conference and learned all of the things and were very excited about everything.
Yeah.
Do you want to hit some of the wave tops from the conference, perhaps?
Well, I think in several respects, it was affirming of the work that we're doing. So that was good. You're with the leaders in the country who are doing this work, and you talked about the study, and they're like, yes, keep doing it. And you're like, that's it.
Because again, there's no guidelines for CCTA. I think people need to like understand that really clearly. Is like, you know, unlike the calcium score, there aren't like years and years and years of data saying do this and then this is why insurance covers it. Like CCTAing people is super, super new. So it's very affirming, because sometimes you're CCTAing people and you're like, okay, very few people are doing this. Is this really that sensitive or specific of a test? Is it really going to help somebody 20 years from now? I think it's affirming to have, like, yeah, all the leaders in cardiac imaging and cardiology say, like, yeah, it's a great idea to do.
Right. And I think, too, the other thing, I definitely, personally learned and grew on how to do my interpretations of the plaque that sits in front of me on the screen, all of the qualities that make it a higher risk plaque or a low risk plaque. And a big take-home question was, stenosis is only part of the story. And in fact, they're because one of the things that the AI can do is it can factor in fluid dynamics to see if you have reduced blood flow beyond the area. So you can now look at the area, and they're looking at, for patients at least between 40% and 90% stenosis, doing those studies. It's called FFR, looking at that. And also you look at the lesion and you say, okay, this is a 40% heavily calcified lesion. I'm not so worried about that. Now, this is a 40% lesion, and we have right next to it here is very low density necrotic core, or we see something that's called positive remodeling, where you actually see the artery either get a little bit bigger, get a little bit smaller due to the plaque deposition, or you see spotty calcifications. Those are all high-risk issues. And you're like, yeah, I think I'm going to have you just go and talk to the interventionalist and see what they think about this. And should we, I feel like what I learned so much that my interpretation is going to be a little bit different and even more thorough than it was in the past. And for me, one of the mind-blowing statistics that they talked about was, I have to check my board so I get this right. So there's been tons of progress in cardiovascular care, massive, right? So we could throw stents in, we could do all these things, but mortality for those between 35 and 60 hasn't really improved. And you go, well, why is that? And part of it's because we don't look for it. We don't look for plaque in younger people. And so when you have your first bout of chest pain, so about 1/3 of people will go on and have a stable ischemic event. The other 2/3 will have either MI or death. So so when we're talking about these things, and in that area, the only way to know is to look.
I'm writing that down.
Okay, yes. I mean, it's crazy.
Way
Like
to know
we do
is
all
to
these
look.
fantastic things, but like Jeremy mentioned, there's just this wait until you're in the secondary prevention category.
I just take a big deep breath. I want to talk about the call.
Oh yeah,
Because you have to make some of these
yes.
calls.
Yes.
How do those go?
Well, typically, so the study comes in, I take a look at it, and some are no-brainers. You're like, ooh, this is 90%. This definitely, so I'm going to do a couple things right away. One is I'm going to consult with intervention just to let them know what I'm dealing with. And then I'm going to call the patient, and I always tell them that we found something on the exam that's concerning. I ask them about, are they having symptoms at that moment? Because that changes, are they going to come see me or are they going to go to the emergency room? And come in, I welcome them to bring spouse, significant other, so we can go over the test, what I'm seeing, the different plans of action that we have, and then we make a decision and go forward.
Wow. Just wow. I want to kind of summarize and then invite you to hop in with more information. But I think that the listeners need to understand the enormity of what you are doing. You are taking people that do not currently or may not currently have symptoms. These people may have had an EKG and a clean calcium score, and they may be skipping along in life, and you are identifying a potentially lethal condition in these people. Did I get that right?
You did. Yep.
And you are currently the only fire department that I know of that is doing this.
I think there's a couple modified approaches, but I don't know their details very well at all. And
Very few.
And I don't know how they're doing follow-ups and so on. And we're super fortunate here at South Metro to have both Jeremy and myself be able to look at every single test immediately and make sure that somebody has follow-up. Like that's what it gives me a great deal of comfort knowing that we look at everything right away. There's nobody who's going to go to bed and I don't know about what they've got going on in their heart and they don't know about what's going on in their heart. We're going to see it and take care of it.
Dr. Carrie and Jeremy are on the job. I love it. I worked on a position stand a couple of years ago for the International Society of Sports Nutrition for fueling police, fire, and military. And one of the things that we sort of dropped in there was in these populations, we could potentially see complications of extreme levels of caffeine intake due to the fact that there could be underlying cardiovascular disease, or now that I've talked to y'all, subclinical cardiovascular disease. Can you just, because this population is addicted to caffeine, let's just put it that way.
Yes.
It is not unheard of for firefighters to be consuming 800 milligrams to, I've seen up to 1.5 grams of caffeine per day. And they're like, it's fine. I'm fine. Everything's fine. The world's fine. My friends, your heart might not be fine. Can you comment?
Yeah, so that's a good question. As far as caffeine goes, we definitely have a lot of people who are addicted to caffeine. You mentioned saying up to 1.5 grams. I think we had a patient who was close to 3 grams a day. And it's kind of hard to fathom, but he did have significant enough plaque on his scan to get cathed. I will say that caffeine currently is not officially known to be a modifiable risk factor of coronary artery disease. So I definitely don't want to overstep and say if you're addicted to caffeine, therefore you're going to have coronary artery disease.
Right.
But I can say anecdotally, we did have somebody who was drinking more caffeine than I thought was possible for a human to drink and be compatible with life. And had significant artery disease at a pretty young age. Well,
my concern is always, so you have this potentially lethal disease process going on, and you're revving up your heart rate to whatever levels, and you're going to structure fires, and you're getting dehydrated.
And that's a good point. I guess I should say, while it's not like a risk factor for developing plaque, as far as we know, if you do have an existing stenosis and you're causing vasoconstriction and increased ionotropy of your heart by caffeine, that's not going to help your circulation.
I like that. It's not going to help.
No.
Oh my Lord.
And we had an interesting thing too, because of a caffeine addiction. When we had patients withhold caffeine for their tests, several had caffeine withdrawal, and they were so tachycardic from that we ended up saying, okay, look, go have a cup of coffee and go back to the scanner, and then their heart rates would be back normal. So we have to be like, when we're handing out the beta blockers, as we evaluate every patient, is, we specifically ask about caffeine use and timing so that we can get this right.
Jeremy, just to recap, you said 3 grams.
Yeah. I honestly had never met anybody who was even close to that. I didn't even know you could do that in the upright.
My 800 milligrams is amateur hour that I was talking about.
Yeah.
Whew. All right. I want to be very respectful of your time. I would like to give you the opportunity, both of you, is there anything that we should have dug into either deeper or I didn't hit on it at all? The mic is yours.
I think I want to talk about our pilot group, because we do have 1-year data on them, and it was really interesting. So in the group of 23, when they got their first scan, only 4 of them were on any kind of statin or other therapy to control their lipids. So we get the first scan, and then on the follow-up year, 1 of the 4 had stopped taking, and I think 7 had started. But that total just brings you down to about 50% of them on some kind of medication. Their lipids, their LDLs went from 170 to a year follow-up into the 80s. So almost a 50% decline in LDLs. And even those who did not start statin therapy or other therapies showed a decline.
Due to lifestyle changes?
Presumably,
yes.
And that's like the median cholesterol too. So it was like a very big drop. And
I
think that's just like the point is that, like, if you scan people but nothing changes, it doesn't really matter if you scan them or not. I think that was like one thing that was really exciting about the calcium score when it came out, is that they found that people who got calcium scores, even if they didn't get on therapy, they would have a reduction in cholesterol. Because when you tell somebody, hey, your percent chance of having a heart attack in the next 10 to 30 years is 4.8%, they're like, okay, like whatever, like that's not like really earth-shattering news. Mm-hmm. But if you sit down with somebody and you look at their LAD and can point on this color-coded chart and say, this thing that you see in your scan right here is plaque, I think that's a lot more behavior changing and motivating. Mm-hmm. And so, the median LDL dropping by 50%, including people who were on a statin, I think just goes to show that, even if you don't start picking up running 10Ks or whatever, there's probably something in your mind that says, oh yeah, I remember this spot of plaque when you go for your next cheeseburger. There's like something there that's a little bit more compelling than just a risk stratification percentage.
Yeah, this is firefighter brain. You just told me I had a 4.8% chance of dying in the next, 10 to 30 years. I have like a 25% chance of getting hit on the freeway. I'll take my chances.
Right.
Mm-hmm.
But the freeway is now in your heart and you can see it. That's the difference.
Yeah.
Wow.
So I think, take home from the work we did, 309 found a lot of serious disease, had about a 10% rate of significant amount of plaques, and found that calcium score did not accurately predict plaque for our population. Prevent scores did not accurately predict for our population. And the pilot group, dropped their LDLs nicely. So I'm excited, we'll get these others scanned. We'll get 1-year data on everybody else and see how that's going. It's really exciting times, I guess.
For sure. And now we need to get the word out to the rest of the fire service. So
yes,
we'll start with the podcast.
Yes.
And then your paper.
It all starts with you, Annette.
Oh my gosh. The weight of the fire service is now on my shoulders. No, I am so honored that you guys took the time out of your schedule today. I usually ask about dogs. Do you have like 2 minutes to talk about dogs?
I have all day to talk about dogs.
Oh, I love you. All right, we'll start with Jeremy because he's just smiling in the background. Jeremy, do you have a dog?
No, I don't. I'm just smiling.
Do you love dogs?
I like dogs. I just don't have one.
Okay. I was going to have to ask you to leave the room if you didn't like dogs. All right. And Carrie and I have talked a little bit about dogs, but the listeners need to hear about your dogs.
Yeah. So I have 3 Whippets, and they're Tesla, Gator, and Synergy. And we train and we compete all over the country in different sports and have a fantastic time.
Oh my gosh. And do you ever compete in Oklahoma?
I can. I haven't recently. It just depends on where certain national events are and stuff where you go.
Okay. But you'll just have to let me know if you come to Oklahoma. I'll come see the Whippets. Well, I think with that discussion about CCTA, about discovering coronary artery disease in firefighters, and about dogs, I think we've covered all of the important topics that we had on the list for today. Do you think we should drop the mic?
I think so. And I just want to say, for I'm not a big social media person, but you can always contact us through email. And, if listeners have questions, happy to answer them, even if it's like, hey, this has been going on with me. How can I talk to my physician to get this done? Any questions about anything, please go ahead and email. We're happy to answer them.
Amazing. I will drop the addresses in the show notes. My guests, I am so appreciative of you. I thank you so much for your time, and I cannot wait for the fire service to hear this episode. Jeremy and Dr. Carrie and AZ are officially out.
Thank you.
Thanks.